Good morning. The Insurance Committee of the Tennessee House of Representatives of the 112th General Assembly is now in session. The time is a few minutes past 9. Today is March 30, Tuesday, 2021. Mr. Clerk, please call the roll.
Representatives Carr, Sapicki, Freeman, Hawk, Hicks, Hodges, Johnson, Lafferty, Mitchell, Powers, Rudd, Smith, Terry, Thompson, White, Vice Chairman Rudder, Chairman Kumar.
Here.
Mr. Chairman, you have a quorum.
Thank you, Mr. Clerk. Members, do we have any personal orders? Chairman Spicky, you're recognized.
Thank you, Mr. Chairman. Mr. Chairman and members, in Murray County, we had a death, a true patriot to Tennessee, salt of the earth gentleman, Mr. Arthur Haynes passed on, a super great guy, pillar of our community, and just wanted, if you would, just take a moment of silence to honor him and his wife. Thank you, Mr. Chairman.
Thank you. Any other personal orders, members? Seeing none, looking at our calendar, item 1, House Bill 1195 is rolled for 1 week. Also, item 8, House Bill 1379 is rolled for 1 week. We'll call up our second item on the agenda. House Bill 0181 by Chairman Hazelwood. We have a motion and a second. Chairman, you're recognized.
Thank you, Mr. Chairman. This is a hospital assessment bill, and we bring this to you every year to fund a major part of the TennCare program. And there is a committee amendment that makes the bill. Thank you. That amendment is 4830. And what this does, as amended, it will actually bring in $1.7 billion for TennCare. It brings down $602 million from the hospital assessment, and that draws down matching funds, again, to reach the total of $1.7 billion for the TennCare program. This year's bill, the rate of assessment is established at 4.8%, and that's the same assessment as in 2019. All the money that's collected goes in the trust fund to provide the state share of funding. And by having this money, we're able to make sure that we don't have to cut TennCare programs like hospital and physician and other provider rate reductions. We can fund critical access hospitals. There's some funding for graduate medical education in here. And one of the things I want to always point out that the legislation continues to specifically prohibit hospitals from increasing charges or adding a surcharge to the patients as a result from the assessment. This is not a pass-through. This is true assessment on the hospitals themselves. With that, Mr. Chairman, I would stand ready for questions.
Thank you, members. You've heard explanation of the amendment. We have a motion and a second to attach the amendment to House Bill 0181. Without objection, we are voting on attaching the amendment. All those in favor, please say aye. Aye. Opposed? The amendment goes on. Questions been called? Any objections? None. We are voting on House Bill 0181 as amended. This may be one of the largest bills we will vote in this committee. Thank you for bringing it. All those in favor, please say aye. Aye. Opposed? The House bill goes to your own Finance Committee.
Thank you, Mr. Chairman. Thank you, committee.
Thank you. Item 2 is House Bill 0766, Chairman Vaughn. Is Chairman Vaughn here?
Good morning, Mr. Chairman and committee members. I'm bringing you an administration bill today, which involves cybersecurity for insurance companies. What we're asking you to approve this morning is a bill based upon the National Association of Insurance Commissioners Model Act, and there is an amendment traveling with it, which makes the bill, Mr. Chairman,
So this-
5524.
Yes, this is 5524. On the amendment, we have a motion and a second. We can attach the amendment to the bill and that you can explain to us any further that you need to. Without objection, all those in favor of attaching amendment 5524 to House Bill 0766, please say aye. Aye. Opposed? The amendment goes on the bill. You have given us some explanation. Is there anything else you need to add? You're recognized.
Thank you, Mr. Chairman. I don't want to talk myself into trouble, but this model legislation has been approved in 11 states, including 6 around the Southeast. So
We do have a member who wanted to ask a couple of questions. Could you kindly withdraw? Okay. Your friend, Representative Freeman, you're recognized.
Thank you, Chairman. Thank you, Representative Mitchell. So I think this is a great idea, great bill, and thank you for bringing it. I do have one question. The requirement where it would only be required to report if more than 250 Tennesseans are impacted. Can you talk a little bit about why that number of 250 is important, and how many cybersecurity breaches do we have? I mean, I guess I would be, if I'm impacted, I'd want them to know. If you were impacted, I'm sure you'd want them to know and do some research. Why 250, and how big of a problem is this? Thank you.
well, thank you, Representative Freeman. Unfortunately, I'm not a member of the National Association of Insurance Commissioners who brought this about, but I can tell you a little bit about what the concerns are, and primarily what the issue is that particularly our department is concerned about. Number one, this bill applies to companies that have 25 employees or more, so that it's not really going to affect your State Farm or Nationwide insurance agents situation. What they're concerned about primarily is the destabilization of the financial position of some of our insurer and underwriters that are affected by basically these hacking episodes to where they lock up their system and they've got to pay basically ransomware. And so that's what this is modeled towards, that we're really looking to fight.
Great. That's a great answer. Thank you.
Any other questions, members? Seeing none, without objection, we are voting on House Bill 0766 as amended. All those in favor, please say aye. Aye. Opposed? The bill goes on to calendar and rules. Thank you,
Thank you,
Chairman
sir.
Vaughn.
Thank you, committee.
Item 4 on our agenda is House Bill 1015. By Chairman Hicks. We have a motion and a second. Chairman Hicks, you're recognized.
Thank you, Mr. Chairman, and
We have an amendment.
yes, that makes the bill.
This is Amendment 5586. We have a motion and a second on the amendment. Without objection, we are voting to attach the amendment, and then Chairman Hicks can explain the bill, amended bill to us. All those in favor of attaching Amendment 5586 to House Bill 1015, please say aye. Aye. Opposed? The amendment goes on the bill. Chairman Hicks, you are recognized on the amended bill.
Thank you, Mr. Chairman. Amendment 5271 makes the bill. The intent of the legislation is to clarify existing laws so that non-insurance discount dental and vision programs that have operated here in the state can continue to be used and offered to Tennessee consumers. This adds a new chapter to Title 56 to preserve the status quo for dental and vision discount programs while also strengthening consumer protections and streamlining regulation.
Members, you've heard the explanation. Are you stumped or do you have questions?
Thank you.
Seeing none and the question's been called, thank you for your explanation, Chairman Hicks. All those in favor of House Bill 1015 as amended, please say aye. Aye. Opposed? The bill goes on to calendar and rules. Thank you.
Thank you, committee.
Item 5, moving right along, is House Bill 0419. Chairman Spicky, we have a motion and a second.
Mr. Chairman, we have an amendment on the bill.
E-
5653.
5653. We have a motion and second on the amendment,
Makes the bill.
and that makes the bill. We'll attach it, and then Chairman Speaker can explain it to us. All those in favor of attaching Amendment 5653 to House Bill 0419, please say aye. Opposed? The amendment goes on the bill. Chairman Speaker, you're recognized on the amended bill.
Thank you, Mr. Chairman. Thank you, committee, for moving this forward to allow us to get us in this position. This is the chiropractic care bill that I've been working on for 2 years. This amendment we've just put on allows TennCare to cover chiropractic care. They will promulgate the rules for usage and for authorization for patients to use this. We have to find the money for it in finance. We're working with the governors and our leadership to try to find the money to fund this. So our patients in Tennessee over the age of 18 will now get chiropractic care on TennCare. Answer any question, Mr. Chairman.
Thank you for your explanation. Any questions, members? Representative Freeman, you're recognized.
Thank you. I'll stop asking questions. It looks like that, so explain to me, will TennCare be required to get an alternative treatment before chiropractic, or can this be the first step of treatment, or how will that work?
Chairman Speaker, you're recognized.
Thank you. It's a great question. The bill puts it in a position where TennCare will make that decision, whether it's going to be the first treatment or a referral process there, just like they do with all their other physical therapy, et cetera. So it puts it in line with all the things that TennCare does right now. It's just now another tool in the tool belt for help for our people on TennCare, and the department can administer that.
Representative Freeman.
Yeah, so currently, chiropractic services are not, or are they covered under TennCare and other insurance programs?
Chairman Speaker.
So under the age of 18, chiropractic care is currently covered by TennCare. It is not covered over the age of 18. It's surgery, back surgery, or opioids. This is hopefully our physical therapy. This will add another option for people before they go for back surgery or to get on opioids, which we have problems with across the state of Tennessee, as another option to prevent them from having to go on opioids or back surgery. Possibly chiropractic care can help them stay away from that.
Representative Freeman. That's all. Any other questions, members? I think it's good that TennCare is agreeable to covering this needed service, and thank you for bringing this. Without objection, we are voting on House Bill 0419 as amended. All those in favor, please say aye. Aye. Opposed? No. Okay. I think so. The chair will be pushed to decide from a voice vote. Mr. Clerk, please call a roll.
Representatives Carr?
Yes.
Sapicki?
Yes.
Freeman?
No.
Hawk?
Aye.
Hicks? Hodges?
No.
Johnson?
Aye.
Lafferty?
Aye.
Mitchell?
No.
Powers?
Aye.
Rudd?
Aye.
Smith?
Aye.
Terry?
Aye.
Thompson?
Aye.
White?
Aye.
Vice Chairman Rudder? Chairman Kumar?
Aye.
Mr. Chairman, you have 14 ayes and 3 noes.
Thank you, Mr. Clerk. In retrospect, I should not go by the decibels alone. The ayes prevail. The bill goes on to Finance. Thank you, Chairman Speaker. 2 spaces away. Okay. Item, House Bill 0620. By Vice Chairman Rudder. Do I have a motion? We have a motion. We have a second. We have an amendment 5091.
Yes, the amendment makes the bill.
We have a motion and second on the amendment. All those in favor of attaching amendment 5091 to House Bill 0620, please say aye. Opposed? The amendment goes on the bill. Chairman Rudder, you recognized on the amended bill, House Bill 0620.
This legislation amends the current statute on provider-based telemedicine and allows for the use of HIPAA-compliant audio-only technology for behavioral health services if other means are unavailable. With that, I'll take any questions.
Questions, members? Seeing none, and the question's been called. All those in favor of House Bill 0620 as amended, please say aye. Opposed? None. House Bill 0620 goes on to calendar and rules.
Thank you, Chairman and committee.
Thank you. Thank you, members. The last item on our agenda is House Bill 7, item number 7, House Bill 0635 by Chairman Smith.
Thank you, Mr. Chairman and committee.
We have a motion and a second. You recognize. I
Thank
think
you.
have-
And there are amendments that need to be added to get this in the right posture of the committee. Amendment 4514.
My notes here says Amendment 4514 is not to adopt. Do you plan to adopt it?
It was to be added into both. The 6234 was also going to incorporate the language of 4514. So it would be essentially the same amendment.
Okay, I have 6238.
Mr. Chairman, 4514 is included in 6238.
So do we need to consider 4514? We do not.
Thank you, Chair.
So the amendment that we're dealing with is 6238. And this was the amendment that we discussed that was about 8 minutes late. Members, my inclination was that it is acceptable, but I would need the will of the committee. Do we have a motion to consider that amendment? I have a motion and a second. All those in favor of considering amendment 006238, please say aye.
Aye.
Opposed? Okay, amendment is allowed to be considered. Now that we are considering the amendment, do I have a motion to attach the amendment? I have a motion and a second. All those in favor of adopting amendment 006238 to House Bill 0635, please say aye.
Aye.
Opposed? Ayes have it. The amendment goes on. Chairman Smith, you're recognized on amended House Bill 0635.
Thank you, Chairman and committee, for your indulgence. The amendment was accepted from TennCare and to exempt TennCare and Cover Tennessee, to cover kids from the bill, to remove some of the part of the fiscal note, reminding the committee on the intent of this bill. In code, there is conflicting definitions that we're trying to align. Currently in Tennessee Code Annotated 63-6-204, as well as 68-11-205, there is a specific prohibition that physicians or providers who are being employed by an entity, and quote, shall not be restricted or interfered with for medically appropriate diagnostic or treatment decisions. However, throughout the Tennessee Code Chapter 56 and throughout the entire body, we're finding over and over that insurance companies have the ability to override an examining physician or provider's clinical judgment. And what this bill does is it puts definitions in place that if you are seeing a physician or a provider and they are examining you based on their evidence-based medicine, based on their clinical judgment, that they deem a treatment, an intervention, a surgery, a medication as medically necessary, that the burden of proof that that indeed is not medically necessary is shifted to the insurance company rather than what is currently in code, which currently is that it requires a physician to provide the burden of proof that a treatment or a modality is necessary. So this is just permitting Tennessee doctors, nurse practitioners, and providers to practice medicine, and it prohibits the corporate practice of medicine from a sense of a fiduciary standpoint. With that, Mr. Chairman, I'll be happy to take questions of the committee.
Members, we do have testimony from the Department of Health. Without objection, we will go out of session, and Mr. Patrick Powell from the Department of Health.
Good morning, Patrick Powell from the Department of Health. As drafted, the department has concerns and opposition to the bill. It includes titles 63 and 68 and the definitions of medical necessity. I don't believe it is the sponsor's intent. However, it would cause difficulties with the department's efforts to go after bad actors. Instead of a determination of medical necessity being a defense, it would create a presumption that all efforts by a physician or a facility were medically necessary, which then creates a burden that the Office of General Counsel and the department would have to overcome. So in overprescribing cases, things of that sort, we would have to actually go well beyond what we currently do, which is already a challenge, and have to prove that it was not medically necessary. Again, I don't believe this is the sponsor's intent, but it does create some conundrums with the department.
Thank you. Members, any questions for Mr. Powell? Chairman Smith, you're recognized.
Thank you, Mr. Chairman. Would you offer testimony? Is it a practice for insurance companies to recoup payment based on a lack of proof that a physician provides?
And Representative Smith, I apologize. The insurance world is not my forte. I can't answer that. We're merely looking at it from the licensure aspect and complaint kind of side of things, not from the insurance side of things. So any of the language, say in 56 or in that realm, not our department's ballgame, so to speak, just in 63 and 68. And because it is in the titles for health practitioners and for facilities, that's where if we get a complaint, we're going to have to overcome that standard of whether or not it was medically necessary.
Chairman Smith.
If I could ask legal to look up these sections to read for me, 63-6-204.
Sure. Well, Mr. Powell, while we are figuring that out, it's a long section. They are trying to see which one is applicable. So what you said is that it will make difficult for the Department of Health to go after bad actors. Can you give me a more concrete scenario?
A good, I guess, analogy would be in the criminal world, if there was a murder committed, you have to prove the intentional killing of another, and then self-defense is a actual defense. It's not that you have to start at that point proving it's not self-defense. In the medical world, we would be trying to prove that there was a violation of the standard of care, and then a physician could assert that it was medically necessary as a defense, possibly, not from the get-go. So it kind of creates a higher burden of proof and a presumption that we would have to overcome. It would be as if the DAs in a criminal case always had to prove against a defense from the very start instead of the assertion of a defense. I hope that makes sense.
In what way does the Department of Health have to intervene towards a provider who you do not think is using proper judgment in considering various services that he prescribes or considers medically necessary?
Can you rephrase that question, Chairman? I apologize.
In what role would the Department of Health need to intervene towards a physician who is providing or prescribing services that you don't think are medically necessary?
So we are a complaint-driven system. We would get a complaint on a provider, and we would investigate the basis of the complaint. So, for example, overprescribing. We would then look at kind of the standards, standard of practice, have expert testimony as to what the standard of practice is and whether or not that violated either rule or law or professional standards. However, this language, while I know it's intended to be more about reimbursement, creates because it is in Title 63, creates a kind of barrier where we would have to be looking at every action to discipline would have to be something that is not medically necessary. So it creates like I said, a higher burden that we'd have to overcome. Again, I don't think that's the sponsor's intent, but it does have that unintended consequence.
Well, thank you. Does this also include actions by the health-related boards?
Yes, sir. That's what in fact, that's what I mean, because it is all actions that the department takes on behalf of complaints on BME, BOE, Board of Nursing, so on and so forth, including healthcare facilities in Title 68. So it's all health-related boards. If we get a complaint, in a sense, those providers are, because of the way the statute's drafted, their actions are, in a sense, presumed to be medically necessary. And we'd have to overcome that on any kind of complaint or disciplinary action.
Thank you. Chairman Smith, you're recognized.
Thank you, Mr. Chairman. And to my colleague from the Department of Health, if you look in Section 11 of the bill,
And I apologize, I do not have a copy of
it's
the.
63-6-248. It reads in Section 11, subsection B, the definition of medical necessity and medically necessary within this section does not affect proof of medical necessity or medically necessary as it relates to past, present, or future medical treatment or medical billing and personal injury actions, healthcare liability, or wrongful death.
So at least from the sound of that, Chairman, and I apologize, I don't have a physical copy of the newest amendment. It sounds like there is a lot of language in there that would protect on the civil action side of things, but not necessarily the administrative law side of things. So if, for instance, I was your physician and I did something inappropriate, you might be able to sue me in civil court for monetary damages. And it sounds like that language is intended to kind of not create a new burden there. But I'd need to see the new language, but I didn't hear anything in regards to the licensure action or administrative law portion, which is where our concerns would be.
Chairman Smith.
I mean, I would have gladly worked with you if I'd heard from you at any point during the week. And this bill has been amended multiple times.
Yes,
And
Representative.
so,
My apologies, I didn't mean to cut you off.
so to that end, Chairman, I'm happy to accept administratory language, but it's going to be at the discretion of the chairman because this bill has already been rolled once, and I don't want to put this committee in a position of inconvenience. But again, my office is at 644. It's been there for 3 years, and I'm happy to work with you if you also provide that.
Yes,
Thank-
Representative.
Yes, Mr. Powell.
My apologies. Obviously, I'm shorthanded at health. Obviously, our assistant commissioner has recently gone to the governor's office, and my other liaison is in quarantine. So my apologies, Representative Smith. I'm very shorthanded this week, and I'm My understanding is that I was under the belief that Alexa Witcher had shared some of our concerns. I apologize if if our language and our concerns did not get adequately relayed, but I'm happy to send suggested language to you, Representative.
Well, thank you. Obviously, it appears there are some matters to be cleared and things that need to be streamlined. Do we still need to, for the section that Chairman Smith, you want to read, do you still need for it to be read?
I think it would be helpful for legal to read the two sections that I spoke to her about in 63 and 68, just for the sake of having it read into testimony, where our code currently speaks to prohibitions of directing medical decisions.
Ms.
Thank you,
Shanks,
sir.
you're recognized.
Thank you. I've been asked to read 63-6-204, subsection C. Nothing in this section shall be construed to prohibit a person, corporation, organization, or other entity from employing a physician to treat only the entity's full-time, part-time, and contract employees, the entity's retirees, and dependents of the entity's employees or retirees, provided, however, that the employment relationship between the physician and the person, corporation, organization, or other entity is evidenced by a written contract, job description, or documentation containing language which does not restrict the physician from exercising independent medical judgment in diagnosing and treating patients. Under this section, such person, corporation, organization, or other entity shall not be deemed to be engaged in the practice of medicine. The other section I was asked to read was 68-11-205, subdivision C1A. To give it context, I'm going to read the introductory language of C1. Notwithstanding this section, nothing shall prohibit a renal dialysis clinic licensed under this chapter or an affiliate of a renal dialysis clinic from employing physicians other than radiologists, anesthesiologists, pathologists, or emergency physicians licensed under Title 63, Chapter 6 or 9, subject to the following conditions. A, employing entities shall not restrict or interfere with medically appropriate diagnostic or treatment decisions.
Chairman Smith, is there anything you need to point out?
I would, thank you, Mr. Chairman. Simply that in code, we have already demonstrated that it is the will of this legislative body and the state of Tennessee to allow physicians, providers to practice medicine, rather than having financial decisions made on the backs of patients. And if the committee would so entertain this, I will ask the chairman to roll this to next week's calendar for the purpose of working with a friendly amendment to accommodate the department. But I would ask that you do that by the end of tomorrow, please, sir.
Thank you. We can do that. But before doing that, we do have other testimony. And if certain issues come up, then it will be nice to filter them out today so that they can be also incorporated as you work to amend your bill. Chairman Hawk, you're recognized.
And thank you, Chairman. And the committee apology coming from the subcommittee, Mr. Powell. I apologize. The issue, I did try to approach the issue in subcommittee last week by making a statement, but we did not have Ms. Witcher on the list to speak to us about this particular last week. So I accept blame and I accept the blame for that, Mr. Chairman and members. Thank you very much.
Mr. Hawk, you're very modest and generous. It's a large bill with a lot of angles to it and a lot of code to be understood, what exists previously and what we are trying to modify. And I can understand that really all of this could not be covered in one subcommittee session, or it appears one full committee session for that matter. Any other questions for Mr. Paul? Seeing none, Mr. Paul, thank you for your presence. Next, we have on our agenda Mr. Scott McAnally from the Department of Finance and Administration. Welcome, Mr. McNally. As you know the routine, kindly
Yes, sir.
introduce yourself and proceed.
Thank you, Mr. Chairman. Scott McAnally, Division of Benefits Administration. Thank you and members for the opportunity to discuss House Bill 635 with you this morning. Benefits Administration does not maintain our own definition of medical necessity for the state group insurance program. We defer this function to our contracted carriers specifically in our plan documents. However, we have seen the definition of medical necessity that at least one carrier uses in their provider handbooks, and it looks the same as the existing definition of medical necessity referenced in Title 56. That definition holds that services are medically necessary if they are in accordance with generally accepted standards of medical practice, if they are clinically appropriate, not primarily for patient or provider convenience, and not more costly than a therapeutic or diagnostic alternative. House Bill 635's definition removes the standards of medical practice, clinical propriety, and not for the provider or patient convenience requirements with any service that an ordering provider determines is in the patient's best interest, rather. The definition does retain the not more costly requirement, but only if the alternative treatment is suitable for the patient's best interest as determined by the ordering provider. The bill also creates a presumption that an order from a physician that has physically examined a patient is in the patient's best interest unless substantial evidence can be produced that the order is not in the patient's best interest. Changing the standard for medical necessity is expected to have an impact on our claims. In 2020, according to our carriers, medical necessity reviews resulted in $40 million worth of avoided costs through denials, prior authorizations, pre-certifications, and other utilization management, utilization review functions. In consultation with our actuary, Benefits Administration projects that an impact of about $26 to $28 million of those claims will be paid under the amended bill. Chairman Kumar, I've been working to follow up with your question from the subcommittee about how denied claims are reviewed to make sure that they're being adjudicated correctly. One way to trigger a review of a denied order is through appeals. One carrier has reported an average of 27 claims per year that are denied on grounds of medical necessity, later overturned when a provider is able to furnish appropriate documentation that the order is medically necessary. None of those denials and appeals resulted in a delayed date of service. Our other carriers said they have to manually research that information, so they've not submitted it to us yet.
Thank you, Mr. McNally. Could you kindly do me a favor? You made some very good points at fast speed. Can you summarize 1, 2, 3, the three
Yeah.
main points kindly summarize your.
I think the high level summary is we defer the function of claims utilization to our carriers, and they adjudicate medical necessity by a definition that they come up with. They've, in 2020, avoided costs of about $40 million worth of claims. Under the new definition of medical necessity, both how it's defined and how it will be implemented, I think as a colleague from the Department of Health said, and shifting the burden of proof from the payer to the provider, we would anticipate paying on about $26 to $28 million worth of those claims.
Thank you. Chairman Smith, you're recognized.
Thank you, Mr. McAnally, and I appreciate you sticking to your testimony that you offered in the Council on Pensions and Insurance, which gave this a favorable recommendation upon the exit and the review there in the Council on Pensions and Insurance. One thing I just want to make sure to revisit is in your statement that you saved $40 million through denial and utilization. One of the things that I want the average person watching online and all of us to appreciate that the way insurance companies save money for the plan sponsor is through reducing utilization. Is that correct?
I would say those are avoided costs.
Okay. But the premiums paid by the policyholder don't change whether you receive care or you don't receive care. You pay your premiums on a monthly basis for care. Is that correct?
You do
Mr.
pay
McNally?
thank you, Chairman. You do pay your premiums on a monthly basis. As a self-insured plan, when we avoid costs, we don't collect any compensation. We're just paying claims out of reserve. So to the extent that our reserves are paying out less, the need to increase our premiums is fewer. When we've had zero, we have premium holidays. I think we have coming up this year, actually, where the fund was overbalanced. We've also had instances where we have an increased premium before. So the claims impact does have a direct relationship with premiums.
Thank you, Mr. Chairman. And just for the average person, again, while we're talking about claims and adjudication and denial, essentially we save money by denying care.
I would say those are avoided costs, but those are claims that were not paid.
Thank you, Mr. Chairman.
Adjudicated non-medically necessary.
Thank you. Well, looking at, is this an absolute if we are shifting the burden of proof either from provider to insurance companies or vice versa? Is there not a middle ground good balance where prescribers are checked upon not overprescribing services and insurance companies are held responsible so that they are not over denying care?
Thank you for the question, Chairman.
This is a question for both sides. really.
Okay, yes, sir. So I think as a plan, because we're heavily deferential to our carriers, we don't really carry clinical staff. We don't have a lot of insight onto. I think we consider our current medical necessity standards to be working. We have an appeals process. We believe our appeals process is adequate. If it's adjudicated to not be adequate, we'd certainly be happy to look at that. In terms of how those denials are reviewed, again, we've asked of the carriers, and it appears that appeals has been their answer for how those are reviewed.
Thank you. Chair Lady Smith, do you want to answer that sincerely? We do have a situation where we can have prescribers over-prescribing or insurance companies over-denying. There does need to be balance rather than either or.
Thank you, Mr. Chairman, and I appreciate the committee's indulgence, and I hope that others find this a thoughtful discussion, because here's where we are in the state of healthcare. In the 1960s, the average patient consumed just over $120-something a year of healthcare. Now it's almost $12,000 per year out of pocket. And so while we have constructed these extreme bureaucracies, some government controlled, some private sector controlled, many are a combination thereof. We're not seeing healthcare costs go down. We're seeing them go up. We're not seeing the quality of care necessarily go up. We're just seeing the consumption of a lot more care that's not necessarily yielding very good outcomes in some cases. And so the purpose of any bill that I have ever carried in my 2.5-year tenure for patients is simply because we're hiding prices in the sector of healthcare. We hide prices. We rely on third-party administrators to contract things out, negotiate some prices, leverage some prices. We've seen the vertical alignment of healthcare. Insurance companies now own PBMs, which now own specialty infusion pharmacies, which now own doctors' practices. And we're seeing costs go up. And so to the degree that our chairman here practices or did practice medicine, and that people are relying more and more heavily on healthcare, we need to understand what healthcare is. And my goal here is to absolutely address the bad actors in both cases. Most legislation is to dictate the tails of a bell curve, those that practice on this side and those who practice on this side. And unfortunately, we're witnessing the corporate practice of medicine in the state of Tennessee. We're watching the reimbursement. CMS has already broadcast for the last 3 years. Medicare reimbursement is going to go down 10% within the next 5 years. Insurance companies will follow on the commercial side. So the intent of this bill is to bring attention indeed to the bad actors. You still have that mechanism. That burden of proof is still there. Mm-hmm. And so, yes, I'm happy to work with any entity to right-size this, but we really do not have consistent definitions through code, and we certainly don't have consistent applications. And I would ask one more question of the chairman. Is there one definition of medical necessity or medically necessary used by all the third-party administrators? Is Blue Cross Blue Shield's definition of medical necessary the same as United Healthcare, which is the same as Aetna, which is the same as Cigna? Because while we are working hard to have a uniform statement and code, I would submit to you that the men and women who are practicing healthcare don't have a uniform definition, and all they're having to do is fly by the seat of their pants, waiting for an approval here, a utilization review there. And I'll sit and listen, but thank you, Mr. Chairman, for your indulgence.
Oh, thank you. Chairman Smith, you are bringing very, very big subjects to the table, and thank you for making us think about it. However, certain statements that the cost of healthcare has gone up, and of course, we know the reasons it has gone up. Utilization is one part of it, but also the various medical advances are a major part of it. And the fact that quality of healthcare has not improved, I would submit to you it has improved tremendously. We are living longer than ever, and the treatments for various common diseases, including heart disease, have really taken major leaps in progress. These are big issues, and I think, again, we need to have a balance between overprescribing and over-denial. Chairman Hawk, you're recognized.
Thank you again, Mr. Chairman. And I know, Mr. McAnally, your expertise is more in numbers than it is in some of the structures of the conversation that we're having. So I understand that completely. Where we're trying to get is that happy medium. We're trying to get to the place where patients are the focus, where we've got an understanding from both insurance companies and providers that we need to focus on the patients. As we're looking at this, and we certainly passed the bill out of subcommittee last week with the intention of hearing the committee, the amendment that was going to reduce the fiscal note. We've got the amendment that we just adopted is taking TennCare out of it, so it's taken $70 million out of the cost, but there is still a cost to the state of Tennessee and the state insurance plan. That's what we're talking about now with having your testimony.
Yes, sir.
And as I look at that, I'm hearing costs go up. I heard this statement a moment ago. Costs go up. The question I've got, who is paying for those costs? And it's still going back on now the back of our state employees, the way I'm visioning this, because as I look at the fiscal note, $4.8 million in year one because of costs associated with the piece of legislation, but year two, $9.7 million, and that's probably going to be in premium increases where the state is having to take up a greater dollar value of the premiums that they're paying on behalf of our state employees, ourselves included. So I'm still concerned about us getting to a happy place, even with this piece of legislation, because the premiums are still going to go up, not only in the state plan but also in the private insurance plans as well. And the conundrum I have that I'm trying to wrap my mind around, are we getting to the goal of actually helping that patient? A lot of rhetorical conversation right there. I don't expect any answers. I just put that out there for the committee as we consider this. And thank you for your testimony. Thank you, Mr. Chairman, for allowing me to expound.
Thank you, Chairman Hawk. I was asking for balance. You're calling it a happy place. So I think we are on the same page. Mr. McAnally, do you have a comment?
I don't think so.
Okay. Chairman Terry, you recognize.
Thank you, Chairman. And I don't disagree with the two chairmen about, having a happy medium or a balance in this. And some of the ideas and things that are potentially thrown out there, and again, this is just for digestion here, prior authorization and utilization review. Yesterday, I spent probably 45 minutes on the phone on a prior authorization on a medicine, trying to help my mom out on this issue. And that's just, something from a patient standpoint, from a consumer standpoint, from a provider standpoint, the burden being on something that's been a stable medication for a while, and that provider saying that it's medically necessary, but then again, the time and effort and all that is something that it's a burden. And those are things that we need to look at that can streamline this for patients. I don't think it'll change the cost. It might actually decrease the cost on some of these because of the time that those individuals that were on the phone with me had to spend. So I do think there's work that we can do on this. Again, how we find that happy medium, how we find that balance. I'm willing to work whatever we can do for these patients. So thank you.
Thank you, Chairman Terry. Yes, you raise a very good point in the sense that all of us those of us who practice medicine did spend sometimes a lot of time with the utilization review and insurance companies and so on. Next on, thank you, Mr. McAnally. Next on our agenda is Mr. Bill Huddleston, Mr. Patrick Merkel, and Mr. Alex Lewis are available from the Department of Commerce and Insurance.
Bill Huddleston, Assistant Commissioner with Department of Commerce and Insurance.
Welcome.
Mr. Chairman and committee, thanks for your time this morning and giving us the opportunity to come in and talk about some of our concerns. And really, the prior testimony did make me think of a couple of things that I'm gonna add. At the department, as we said before, our goal is it's consumer protection. We do that through solvency monitoring and market conduct monitoring. The result of that, we hope, is something that is an affordable, sustainable product for Tennesseans to buy for their insurance needs. In sum, our concern is the what Chairman Hawk spoke about a moment ago, increased premium costs. So Chairman Hawk kind of stole my thunder there, but that's our big concern. I'll kind of go through the reasoning just a little bit, and it starts with that the current standard for medical necessity that's in Chapter 56, that is based on model language that has been adopted by most states. I think my last count was 45 states. So the landscape and the regulatory environment that's from state to state. That's the standard for medical necessity when it's defined. This bill changes that dramatically, and the result that we see could be instability in the regulatory environment and the process for those costs, healthcare costs that end up being passed on in the form of increased premium to consumers. So while I agree that this does help some people, that ultimately those costs are paid by everybody that is a policyholder. And I think that's, in sum, we're just concerned about the increased premiums that could result. I'm happy to take any questions.
Thank you, members. Do we have questions? Chairman Rudd, you recognize.
I've been listening to this, and this has come up in years past, and we obviously have several issues here, several problems here. And we have I guess what originally created this, the problem is the insurance industry itself and government to a degree. Doctors, and this is my opinion observing because I'm not a physician or an insurance agent, doctors are ordering too many treatments to cover themselves so their malpractice doesn't go up in many cases, and then which is caused by the insurance industry. And then the insurance industry gets tired of they're having to pay all the treatments to keep a malpractice down and cover themselves legally. And then the insurance industry comes in and gets a doctor who doesn't know the patient, who's never seen the patient, to judge that the doctor's judgment is not good because there are too many treatments. So the physician and the patient's caught in between. And every time it seems like there is some type of reform that is proposed, that it's shut down. And we keep basically a failing system that is not doing the doctor or the patient justice. Now, what if not this, what type of reform? Because we talk, well, we need to reform, but we never get reform. Then every time we get a reform, we shoot it down. What type of reform should we have to protect the doctor and the patient?
Mr. Huddleston.
Thank you, Mr. Chairman. I would like to go back to that happy place that you were talking about. I think that's the solution. I'm not exactly sure specifically. It's a problem that I agree that, and a lot of people have tried to work through it. I do think that what we have now is not perfect, but it does serve a lot of people and the services that we do get. But as far as specifics on how to fix that, we could probably talk for a long time about it and still not have an answer. So I don't at this point know exactly a great answer for you on that.
Chairman Smith, you recognize.
Thank you, Mr. Chairman and Deputy Commissioner. Just two questions. In the plans that you oversee here in Tennessee, whether they're ERISA or non-ERISA, is there one single definition that's applied throughout all those plans of medically necessary? So does Cigna and Blue Cross Blue Shield and Aetna and United Healthcare, do they have the same identical definition of medically necessary or medical necessity?
Mr. House?
Okay, yes, Chairman. We do have no, just to be clear, on our ERISA plans, we have no authority, so it would all be non-ERISA plans. And I would want my forms and policy director to confirm this, but the standard for medical necessity is in statute, but from carrier to carrier, it's left up to be defined in the contract.
So what you're saying, the standard is in statute, but the interpretation of it by various carriers can differ.
It's in the contract. That's correct.
Although there is probably overall a fair consistency, they are not completely out of touch with each of those guidelines.
That's right.
Chairman Smith.
Thank you, Mr. Chairman. And one other question. As it relates to insurance, could you give me just a working man or woman's definition of what insurance is?
Sure. I think the best way a working man or woman would put it is sharing financial burden or obligation that might come up.
I would add to that sharing risk, certainly, as you said, is there, but also at times, from a working person's point of view, is the expectation that insurance will pay everything. And that is not understanding the fact that insurance is for events that are rare but expensive, not for every event, because if the cost of payment from insurance approaches the cost, then the insurance premiums will not help. Premiums will be the cost of the service itself. I think I made it clear or not. Chairman Smith.
Thank you, Mr. Chairman, and thank you, Deputy Commissioner. I think what we're seeing in this committee, which is charged to be the Insurance Committee of the House of Tennessee, is that we have a mess in healthcare. And if insurance is defined as a financial product that is supposed to insure against financial ruin and to manage risk, and yet we're arguing over how an insurance company defines medically necessary, I think what we're seeing is the convergence of a lot of circles that we're allowing bureaucrats that never touch the patient, never see the patient. We're allowing individuals who never see a patient to overrule the clinical judgment of those who do. And with that, Mr. Chairman, I will stand committed to take friendly amendments to put this particular issue throughout our code to be consistent for the health of not just patients, but providers, as well as insurance companies. But I think what we're seeing here is a very healthy conflict that we can either choose, as my colleague Mr. Rudd said, we can choose to fix this or push it down the road and continue to let prices increase and patients remain concerned about their care. But thank you, Mr. Chairman, for your indulgence.
Well, thank you. You're being very generous in and open to suggestions. And I would also, I think we are grateful to Chairman Rudd for bringing up the fact about the pressures of liability or malpractice lawsuits that impel certain times to overutilization or overprescribing by physicians under that. Thank you. Chairman Rudd, do you have a comment? Your name was called twice.
No, Mr. Chairman.
Thank you. Any other questions for Mr. Huddleston? And Mr., is that Marco? Yes. Seeing none, gentlemen, thank you for coming.
Thank you, Mr. Chairman.
Next up, we have Mr. Ben Sanders, Executive Director of Government Affairs with the Farm Bureau Insurance, Tennessee. Well, Mr. Sanders, welcome. Identify yourself.
Thank you, Mr. Chairman. I'm Benjamin Sanders with Farm Bureau Health Plans. I'd like to thank you for the time today. I'd also like to thank the sponsor for her time over the last few weeks to discuss this bill. We often have different opinions on policy matters, but we very much agree on open discourse and open dialogue, even when it's a healthy conflict, as was mentioned earlier. So thank you. Of all of the aspects of a health policy, benefits, coverages, networks, all these things that a health insurance company does, our members consistently tell us the most important to them is the cost. What they pay out of pocket is their highest priority. Because none of those other things matter if they can't afford the insurance that we're selling. And when it comes to the cost impact of legislation that you all see all the time, we often hear companies can absorb the cost. And let me put that in perspective. Last year, the highest profit margin of any insurer, health insurer in the country, was 5.26%. The average health insurer margin is around 3%, depending on the year. Now, of course, over hundreds of thousands of policies, that adds up. We don't struggle to keep the lights on, but we do struggle to manage the cost. I don't think any company would operate for free, but consider this hypothetical. If insurance companies operated at zero profit, operated for free, medical inflation clocks in at about 6% per year. So even if a company operated for free, we're still going to see premium increases because of simply the margin of medical inflation. Now we hear also on a number of pieces of legislation that it's just a few dollars per month. We hear that mostly in coverage mandates that we discuss. I bet nobody in this room, myself included, notices when their insurance goes up a few dollars a month. But there are people all over the state that $10 makes a difference between buying insurance and not buying insurance. Now, most people are not on the brink of affordability, just to be honest, but that doesn't mean they're immune from the economic reality. Most families, when they see rising premiums, they'll sacrifice other spending for their families and their kids and their retirement to continue that health coverage. Or businesses, when they see premiums increase, they evaluate whether they should keep offering coverage to their employees or just drop that coverage and invest in other parts of the business. Dr. Kumar mentioned a balance, and I think that's a great definition of what we're talking about. Personally, I'm proud of how the insurance industry, how my industry maintains the critical balance of access to care and managing costs. And it's a balance. Too much management, if you will, and we limit care, as has been discussed, and too little, though, and we limit affordability. We use tools, albeit them unpopular tools, like medical policy, step therapy, prior authorization, prior certification, and utilization review to manage those costs. Now, nobody gets it right all the time, which is why all of the tools that companies use are underpinned with consumer safeguards and sound medical policy. And that policy, I want to note, is not developed internally by a company. We look to medical professionals themselves. national boards, research institutions, literature to make sure that our medical policy is developed by those on the forefront in that area of healthcare. Now, when it comes to these tools, if you will, there's I'd thought earlier Representative Smith of the phrase healthy tension, but healthy conflict, I think, is also a good phrase. There's a healthy conflict, a healthy tension between companies and healthcare providers. And that tension, I will say, helps maintain that balance, that critical balance between care and affordability. Everyone needs checks and balances and push and pull. If a provider's course of treatment is contrary to the medical policy developed by their own peers, it seems reasonable that they should actually carry the burden of proof when it comes to these treatments. Now, I recognize that these tools can be frustrating at times, and that's probably an understatement. But the reality is that approximately 95% of all covered claims are paid without question. That doesn't mean we should ignore that 5%, but let me say that again. Approximately 95% of claims are paid without question. I'm proud of how our industry strategically uses these tools on a small number of claims to maintain that balance. And we believe respectfully that reversing the burden of care has the very real potential to upset this balance. Mr. Chairman, we appreciate your indulgence to let someone from the carriers and the insurance community speak. We very much appreciate the sponsor and her dialogue and discourse on this bill. I'm happy to answer any questions.
Thank you for coming. You make valuable points, and I think we don't realize that. We only remember the time that we had difficulty with an insurance plan and not the 95% that got paid. I think those points are there. Chairman Speaker, you're recognized.
Thank you, Mr. Chairman. I try to know everything I can about education. I read it and study it, and I try to do my best in insurance. I don't know all the answers in insurance. Trust me, I'm trying to learn here as I go. The thing that's frustrating to me is I keep hearing money. Money, money, money. Okay? Tell me about the care. How do we get to a healthy conflict or a healthy, whatever you want to call it, a happy place, that we can take care of people that is fair and equitable to the insurance companies and provide the necessary care for the patient? I keep hearing money. Stop talking about money. Tell me about care.
May I respond, Mr. Chairman?
Sure.
Chairman Spicky, that's a good point. I have two immediate thoughts. One is not to sound trite, but we are only talking about money. Insurance is just what we pay for. We can't tell a doctor or any healthcare provider what or how they can practice or what they can prescribe. And we can't tell a patient what treatment they can get. All we can do is talk about what we're going to pay for. Now, understand that's divorcing the reality of affordability from out-of-pocket cost with healthcare, but we're only talking about the insurance coverage on it. I look at insurance as a fiduciary. So when we are paying for someone's claim, we're paying for it with everyone else's premiums. It's incumbent on us to find that balance to make sure that what we are paying for with other people's premiums is not just cost effective, but medically appropriate as well. And I'll say again, it's a balance. Nobody gets it right all the time. But then the third thing that I will note is that it's in a company's best interest for someone to get better and to get well. I hear what you're saying and some of your colleagues have said about care. Sir, we want people to get well too. I never thought, Mr. Chairman, I can't believe I'm going to say this. I never thought I would quote Senator Nicely in a committee, but he made a good point recently when he said, insurance companies make money when you're healthy. Others make money when you're sick. So we want people to get healthy. There's a vested interest to take care of our policyholders, sir.
Thank you, Mr. Sanders. Chairman Speaker, you recognize.
I appreciate that answer. I don't know if it was the answer to my question, but it was an answer to a question. You know, one of the things, it's going to be more of a statement, Mr. Sanders. One of the things I struggle with all the time is, you know, we get all these different opinions from people coming up here. Health Department, Commerce, experts. Chairman Smith does her, trust me, I know she does her homework. I'm going to be frank with everybody here. I do not like that TennCare was taken out. I do not like that. TennCare is sitting here behind you, Mr. Sanders. They know I have an adversarial relationship with them, but it's a healthy adversarial relationship. Sometimes I win, sometimes TennCare wins. But to unilaterally take them out of this bill, I think is wrong. That was not what I voted on in subcommittee. I voted to leave them all in. So that's my first problem. Second problem is when you shift something all to one side, do you get the best results? When there's not the proper checks and balances, the healthy adversarial relationship, and let's face it, it's an adversarial relationship between insurance companies and providers. That's the system that works. If we skew that one way or the other to an advantage, are we going to get exactly what we want, or are we going to get abuse? There's a lot of good ideas in here. Are they the right ideas at the right time? I don't know. I wish we were in education because Chairman White and I sitting here, we'd have a better handle on this. But I'm not. And I'm telling you right now, I'm struggling with this bill because I don't want to give somebody an advantage over other that's going to create an unlevel playing field. And you know my background, unlevel playing fields never work out. And if we can keep the providers with what they're able to argue for, and we can keep the insurance companies what they're able to argue for, and our job is to basically play referee to make sure that that balance stays intact, I think we get the best care for our citizens. Because I can tell you this, in my travels in sports, I played in other countries. As bad as people may think our healthcare system here is in the United States, it by far leads the world, and that's why people come here for our medicine. So I guess right now I'm telling you, I'm struggling with this. I wish we had more time as sending a message so that we could consider this more and get more people at the table to make sure we get it fixed and get a healthy balance. Thank you, Mr. Chairman.
Thank you. Thank you, Chairman Speaker. Chairman Smith.
And thank you from the chairman, because I do my homework, and I also want to thank my colleague, Mr. Sanders, because I do know that you prioritize your members and patients. One of the things that I want everyone to hear as active members that are engaged on this committee, you know, moving TennCare, Cover Tennessee, Workers' Comp came out at the request of those departments to save this bill. And I'm happy to roll it to the end of this calendar. Happy even to have further discussions. But here's what I would tell you, and I think my colleague, Mr. Rudd, hit on this earlier. We have a healthcare issue, and we're trying mightily to reform it in this state. But killing bills for the sake of trophies and for interest we've got to come to the table with answers. And so I am fully committed to work with anyone on this committee and anyone in this room for a favorable outcome on this definition or anything else relative to network adequacy, et cetera. But I think that my colleague, Mr. Sapicki, nailed it. We have to have a balance. It has to be transparent, and we have to agree. Profits are not ugly. I mean, you do understand that most of us are Republicans, right? Okay. Profits are not ugly. But what I would tell you is patients are the key of healthcare. And without patients and without providers, there's no need for insurance companies. So with that, Mr. Chairman, I will stand at the wishes of the committee. Thank you.
Thank you. Members, are there any questions for Mr. Sanders? Seeing none, Mr. Sanders, thank you. You bring good thoughts, and we appreciate it. Thank you. Members, we'll go back into the session. We are back on the bill itself. It has been certainly a thought-provoking discussion. It's been therapy for Chairman Speaker. And it has been ventilation for some, but it has been thought-provoking because we are dealing with, again, the gist of the issue being reaching a balance or happy place, as my co-chairman would say, between utilization and and prescription or prescribing, whether it is services or medications or surgical procedures. The only question I have, for Chairman Smith is that as we are looking through the summary of the bill itself, and various provisions are listed, we are not touching on provisions in surgery and other things. Are you comfortable with the way the current practice exists in that regard, or the definition of medical necessity exists in that regard?
Thank you, Mr. Chairman. And working with legal and the various departments, we went through and pulled where medical necessity was listed in code. And so the references that you find are those that are in code. And so how that may be addressed with the application of the insurance plans and policies, it may vary. But relative to our jurisdiction as lawmakers, we only identified the areas in the green books or Tennessee Code annotated. Yes, sir.
And there was nothing about medical necessity as defined in the surgical field. I don't want to open up that field. I think we're fine. Chairman Terry, you're recognized.
Thank you, Chairman. I was just going to make a motion to roll this to last calendar.
We have a motion. Do we have a second? We have a second. All those in favor of rolling this bill to the end of the calendar, kindly say aye. Opposed? The bill moves to the last calendar. Thank you, members, and those who came to testify. Oh, as a second thought, we do stand adjourned. Thank you.